Infectious diseases, preventive medicine and clinical conferences concerning Species 3, 2024 to 2025. Dog diseases. Etiology. The infectious agent responsible for distemper is the canine distemper virus, CDV. It belongs to the genus Morbillivirus and the family Paramyxoviridae. It is a negative, enveloped, single-stranded RNA virus. On the surface of the CDV, we find a virus attachment protein, hemagglutinin or protein H. It allows fusion between the virus and the cell, or between different infected cells, leading to the formation of syncytia. Hemagglutinin is used to distinguish the different CDV genotypes. It determines the tropism and cytopathogenicity of the strain. In dogs, attenuated vaccine strains do not have the immunosuppressive effect of wild strains. Vaccine strains will immunize the dogs, but they will retain residual pathogenicity for other species. They should not be used in other susceptible species. Phylogenetic trees of CDV could be constructed based on the sequences of the coding regions of the CDV H protein, figure. This makes it possible to distinguish 5 groups: vaccine strains, European, dogs and mustelids, American, Japanese, and Antarctic. That strains that are close often share the same geographic area. We also observe that the vaccine strains are quite distinct from other strains. Physical and chemical characteristics to take into account for the fight against canine distemper, green. The CDV is fragile in the external environment. It is sensitive to ultraviolet light and heat, destruction by temperatures above 50 degrees Celsius for 30 minutes. It is rather well preserved by cold, 7 years at 65 degrees Celsius, and by freeze drying, which is useful for the manufacture of vaccines. CDV is stable at a pH between 4.5 and 9. The virus is not very resistant in the environment, less than a day at room temperature, and quickly inactivated by heat, drought and common disinfectants. Canine distemper virus is sensitive to disinfectants such as ether, chloroform, diluted formalin, less than 0.5%, phenol, 0.75%, and quaternary ammoniums, 0.3%. Routine disinfection in kennels and hospitals is normally sufficient to eliminate CDV. CDV is found all over the world. It affects all canids, both domestic and wild. Canine distemper virus is capable of infecting carnivores of the following families: Canidae, Felidae, wild only, Hyenidae, Mustelidae, ferret, Prochionidae, Bosidae, and Vivaridae. Recently, the virus has been identified as responsible for outbreaks in primate colonies. In captivity. Transmission. Transmission of CDV occurs by direct contact between virulent materials and mucous membranes, because survival in the environment is short. The main sources of viruses are aerosols and respiratory secretions containing virus. Other bodily secretions such as urine, saliva, nasal and eye discharge can be infectious if they are in aerosol form. The route of entry of the virus into the healthy body is via the respiratory route. Transplacental transmission has been described but remains anecdotal. Affected animals are very contagious. Indeed, viral shedding can last up to 60 to 90 days post-infection. Risk population. All carnivores of all ages represent the population at risk for distemper. However, young puppies, between 3 and 6 months old, are most affected. Indeed, we sometimes speak of the disease of young age. As the virus is fragile, direct contact with an infected dog is required to contract the disease. Facilitating factors. Several factors favor the development of distemper. Virulence of the strain. Age. The most affected animals are between 3 and 6 months old. Indeed, infection is possible at any age, but puppies are protected until weaning, around 6 to 12 weeks of age, by maternal immunity and adults by vaccination. The immune status of the animal. When the puppy is stressed, immunocompromised or suffers from other infections, it is much more susceptible to CDV. The high density of animals, kennels, exhibitions. After infection, there is rapid multiplication of the virus in macrophages, then dissemination 2 to 4 days after infection to nearby lymphoid organs, such as the retropharyngeal lymph nodes and the tonsils. We observe a first phase of viremia, 4 to 6 days post-infection, associated with infection of the lymphoid organs, spleen, liver, lymphatic tissues of the stomach and intestine. This phase is generally asymptomatic. Then, there is a second phase of viremia, 8 to 9 days post-infection, during which the virus disseminates into epithelial cells. This is the symptomatic phase. Clinical signs. During CDV infection, the animal presents a first discrete peak of hypothermia. Then very quickly, we observe a second peak of hypothermia accompanied by bleeding, conjunctivitis, anorexia and lymphopenia, green. Then the animal shows a variety of clinical signs, which can affect several organs at once. During transplacental infection, infected puppies show clinical signs during the first 4 to 6 weeks of life. The female shows mild to inapparent signs. Depending on the stage of gestation during which the female is affected, we can have abortions, stillbirths or very weak puppies at birth. If they survive, the puppies often suffer from immunodeficiency because the primary lymphoid organs have been affected, and a phenomenon of immunotolerance is described. If the animal survives, it often has after-effects. For example, the dog can develop metaphyseal osteosclerosis of the long bones, neurological signs, multifocal demyelinating encephalitis, known as old dog encephalitis, and hypoplasia of dental enamel. Different observable signs at affected dogs by the distemper virus. Respiratory, cough, dyspnea. Digestive, anorexia, vomiting, diarrhea, dehydration. Ocular, dry keratoconjunctivitis. Cutaneous, vesicles or pustules, hyperkeratosis of the nose and PADS hard pad disease. Neurological, meningitis with hyperesthesia and hypothermia, encephalitis with convulsive seizures, convulsion of the jaws and salivation, myoclonus as short, strong, superficial, and involuntary muscle contractions during sleep, involuntary muscular movements of the muscles of the face and limbs, rigidity cervical, paralysis of the limbs. Prevention. There are 2 types of distemper vaccines, inactivated and live attenuated. The inactivated vaccine is less effective than the live attenuated vaccine and is no longer used today. The live attenuated vaccine is often in the form of a component included in multivalent vaccines, with components against parvovirus and infectious hepatitis. It provides very good protection, which lasts up to several years. KIP, 2012. The vaccine is administered subcutaneously. During an emergency vaccination, the vaccine can be administered intravenously. It only works on puppies, without symptoms, at the beginning of the disease. Prevention. The vaccination program currently used is as follows: primary vaccination, puppies under 3 months, first injection, between the 7th and 8th week of age. Second injection, 3 to 5 weeks later, not before the 12th week of age. Puppies over 3 months, 1 single injection. Certain Duramon, Zoetis, and Nobivac puppy CP, MSD vaccines, vaccines with high antigen titer. However, any vaccination before 12 weeks will need to be repeated. After a single primary vaccination injection, naive puppies develop immunity which generally does not last more than a year. This is why at least 2 injections should be given 2 to 4 weeks apart in puppies who have not received colostrum, or who are less than 16 weeks old. Green, 2006a. Prevention. Reminder: annually and before any entry into a risky environment, kennel, gathering. As adult dogs can develop the disease, it is recommended to give annual boosters, even if vaccination provides protection for more than 1 year. Some vaccines have a longer booster interval by demonstrating the duration of protection, with virulent tests. Indeed, for Nobivac, MSD, and Duramon, Zoetis, after a first booster at 1 year, we can Just revaccinate the animal every 3 years. Regarding the duration of protection of live attenuated virus vaccines, it appears to be several years. The minimum duration of immunity, DMI, varies depending on whether we base it on serology, by antibodies titration, or the response to a virulent challenge. Some authors consider that the duration of protection is at least 3 years. We can therefore afford, after the first booster at 1 year, to do boosters every 3 years. Regarding the establishment of immunity, it varies between 1, Nobivac, MSD, and 2, Duramun, Zoetis, weeks after administration of the second dose. With the live attenuated vaccine, we can hope for protection against clinical signs and mortality. Furthermore, a recombinant vaccine, canarypox CDV, is available in the United States. Canine Parainfluenza virus type 5, formerly called Canine Parainfluenza virus type 2, is very close to Simian Parainfluenza virus type 5. They currently form a single species, Parainfluenza virus type 5, PIV5. It belongs to the Paramyxoviridae family and the Rubulevirus genus. It is an enveloped single-stranded RNA virus. It was first discovered in 1960, in dogs showing signs in the upper respiratory system. The virus is capable of circulating in wild animals, Ursus americanus and Martes pennanti, humans, and non-human primates. The virus is excreted through the respiratory tract of infected animals for 8 to 10 days after infection. Transmission occurs by direct contact via aerosols and contaminated sputum. Transmission occurs quickly because the virus is very contagious, especially when there are many dogs together. The prevalence of infection depends on the density of the dog population, pathogenesis and clinical signs. In the respiratory system, the virus induces damage to the nasal and tracheal epithelia, leading to dysfunction of the mucociliary escalator. Infection in dogs is often restricted to the upper respiratory tract. The animal presents mild symptoms 2 to 8 days after infection and which last 6 days. There is slight hypothermia, a dry and deep cough, a fairly liquid nasal discharge and pharyngitis. The animals remain in good general condition. However, the infection can be complicated by other pathogens, viruses or bacteria, and cause forms more severe, particularly in immunocompromised animals or unvaccinated young people. In this case, the animal is very depressed, anorexic and hypothermic. Diagnosis and immunoprophylaxis. Since a number of other infectious agents, distemper virus, canine pneumovirus, canine influenza virus, canine adenovirus 2, canine herpes virus, canine respiratory coronavirus, can induce similar clinical signs, the definitive diagnosis depends on virus isolation or nucleic acid detection by PCR, nose or throat swab. Serology can also be used to confirm the presence of canine parainfluenza virus 5. Available vaccines are generally included in combination, multivalent, products that also protect against other canine viral and microbial pathogens. Vaccination can complicate the interpretation of diagnostic test results, particularly RT-PCR and serology. The infectious agent responsible for infectious hepatitis is canine adenovirus type A, CADV-A, subtype 1. Previously known as canine adenovirus type 1. It belongs to the genus Mastadenovirus, of the Adenoviridae family. It is a double-stranded, non-enveloped DNA virus. This virus is resistant in the environment. It remains stable at certain ultraviolet frequencies and resists weeks at 20 degrees Celsius and months at 4 degrees Celsius. On the other hand, it is inactivated after 5 minutes at 60 degrees Celsius, making steam cleaning effective against this virus. Regarding disinfectants: resistant to chloroform, ether and formalin. Sensitive to iodine compounds, phenol, and sodium hydroxide. CADV-A subtype 1 is found everywhere in the world, and affects domestic and wild canids, foxes, coyotes, and orcidae, bears. Mode of transmission. Transmission of CADV-A occurs by direct contact with virulent materials, via ingestion of urine, feces or saliva of infected animals. Urine is the most important source of viruses. Contamination by fomites, inanimate objects, and ectoparasites is possible. In animals that survive infection, excretion of the virus in urine can last for 6 months and in extreme cases up to 1 year. The route of entry of the virus into the body, via the oronasal route. Population at risk. Dogs of all ages can be affected by CADV-A serotype 1, but mortality is 100% for puppies less than 2 weeks old. Mortality is 10 to 30% for adults. Facilitating factors. The fact that the virus is resistant in the environment, through the persistence of urine for example, is a factor favoring transmission. Pathogenesis. After contamination via the oronasal route, the virus migrates to the tonsils, then local lymph nodes, to end up in the blood. This viremia allows the dissemination of the virus in the organs, liver, kidney, eyes, and bodily fluids such as saliva, urine and feces. The virus has a tropism for vascular endothelial cells, and renal and hepatic parenchymal cells. Infected cells die and are lysed, creating numerous small petechiae, and sometimes more severe bleeding, if a large blood vessel is affected. In weaned puppies and young dogs, the virus causes fatal hepatitis, subcutaneous edema, ascites, and gallbladder edema. In older dogs, the signs are less marked. We observe hyperplasia of the tonsils, and retromandibular lymph nodes, keratitis due to the immunocomplexes formed. Pathogenesis. The extent of liver damage depends on the blood level of antibodies. If the animal has a high antibody titer, it may develop chronic hepatitis, as part of a persistent infection. If the antibody titer is low, the animal suffers from centrilobular necrosis, which can quickly lead to death. Immune complexes are the cause of glomerulonephritis, which can lead to chronic kidney failure. Virulent and vaccine strains of CADV-A serotype 1, live attenuated, cause kidney damage, which is why only CADV-A serotype 2 is used to manufacture the vaccine protecting against CADV-A. In the eyes, the virus creates severe uveitis and corneal edema. The deposition of immune complexes produces a whitish veil on the cornea, called blue eye. Furthermore, we can witness a phenomenon of DIC, hepatic encephalopathy, or damage to the lungs. Clinical signs. Supracute forms, the animal dies within a few hours following the onset of signs. Classic form, the animal begins by showing fairly general signs: hypothermia, 39.4 to 41.1 degrees Celsius, accelerated pulse, apathy, anorexia and polydipsia. Cervical adenomegaly and inflammation of the tonsils are also observed. Then we observe clinical signs, which affect several systems: digestive, respiratory, nervous, ocular, and coagulation disorders. Prevention. 2 types of vaccines based on CADV-A serotype 1 have been implemented. Live attenuated, provides protection for several years, but can cause uveitis and interstitial nephritis, with excretion of the vaccine strain in the urine. Inactivated vaccine is effective, does not produce lesions, but its duration of protection is limited. This is why we preferred to use the live attenuated vaccine, made from CADV-A serotype 2, which provides protection against the 2 serotypes. In addition, it does not produce kidney or eye damage. On the other hand, the vaccine can trigger mild respiratory illness, especially if the vaccine is inoculated intranasally. It is therefore necessary to be careful about aerosolization of the vaccine at the time of injection. The route of administration is subcutaneous. The vaccination program currently used is as follows: prevention. Primary vaccination. Puppy less than 3 months old. First injection, between the 7th and 8th week of age. Second injection, 3 to 5 weeks later, not before the 12th week of age. Puppy over 3 months, 1 single injection. The Duramun vaccine, Zoetis, with an age for starting primary vaccination of 6 weeks. Reminder: annual and before any entry into a risky environment, kennel, gathering. Some vaccines have a longer booster interval by demonstrating the duration of protection with virulent challenges. Indeed, for Nobivac, MSD, and Duramon, Zoetis, after a first booster at 1 year, we can simply revaccinate the animal every 3 years. Regarding the duration of protection of the live attenuated virus vaccine based on CADV-A serotype 2, it appears to be several years. Prevention may consider that the duration of protection is at least 3 years after the first recall. Regarding the establishment of immunity, it varies depending on the RCP between 1 week, Nobivac, MSD, and 2, Duramon, Zoetis, weeks after administration of the second dose. With the live attenuated vaccine, protection against clinical signs and mortality can be expected. Comparison of the minimum duration of immunity, DOI, of CADV-A serotype 2 according to the serology, or virulent tests. Canine infectious tracheobronchitis, TBI, or kennel cough is a syndrome that can be caused by numerous bacterial and viral agents. These agents, alone or in combination, cause the symptoms. Infection by a single agent often gives crude clinical signs. In general, kennel cough results from the synergistic association of a bacterial agent and a viral agent. Etiology: bacterial infectious agents as Bordetella bronchiseptica. Bordetella bronchiseptica is a gram-negative bacterium. It can survive in fresh water for 3 weeks at 37 degrees Celsius, so contamination from the external environment is possible. However, transmission occurs mainly by direct contact with an infected animal, sick or asymptomatic carrier, via aerosols and sputum. Dogs of any age can be infected, but puppies and immunocompromised animals are more susceptible. Many dogs remain asymptomatic carriers. Bordetella bronchiseptica has a tropism for hair cells of the respiratory system of dogs, cats and humans. This bacterium presents adhesins on its surface which allow it to recognize the hair cells of the respiratory system and to colonize them. Then, it produces exotoxins which damage the respiratory tract and reduce the host's immune response. Depending on environmental conditions, Bordetella bronchiseptica can be extra or intracellular. The intracellular position would explain the escape from immune defenses and chronic carriage, up to 14 weeks. Incubation after infection with Bordetella bronchiseptica is approximately 6 days, can alone cause signs of TBI. Some cases of Bordetella bronchiseptica zoonosis have been described. B. Mycoplasma spp is part of the prokaryotes. They belong to the flora of the upper respiratory system of healthy dogs and cats. Mycoplasma spp has a tropism for the epithelium, ciliated or not, of the respiratory system. In the literature, there are contradictory results regarding the importance of mycoplasmas in the progression of TBI. When we manage to isolate the mycoplasmas in a bronchoalveolar washing sample, we cannot say if they come from the sample, superinfection, or contamination of the sample during passage through the oropharyngeal sphere. Mycoplasmas are generally considered to play a secondary role in TBI. Viral infectious agents: canine adenovirus type 2, canine parainfluenza virus, canine influenza virus, canine respiratory coronavirus, mammalian reovirus, canine pneumovirus, canine herpes virus type 1, canine distemper virus. Epidemiology: circumstances of appearance, reporting of TBI outbreaks is very common. There are epizootics evolution in areas with a high density of dogs, breeding, pet stores, hospitals. Bordetella bronchiseptica can affect dogs but also wildlife, rodents and cats. Mode of transmission: incubation period and susceptible animals. Transmission: adult carrier dogs, to susceptible ones, puppies over 2 weeks old, and naive dogs. Animals at risk: breeding and guarding kennels, shelters, and working animals. Comparison of mode of transmission, incubation period, excretion for the different infectious agents responsible for TBI. Epidemiology. Favoring factors. Certain elements can promote the appearance of a TBI. Bordetella bronchoseptica alone can be responsible for the symptoms of TBI. There is a viro-bacterial synergy. Indeed, the symptoms observed in dogs infected with Bordetella bronchoseptica and PIV5 are more severe than those observed in dogs infected with only one of the two agents. Opportunistic bacteria can superinfect the mucous membranes and darken the prognosis. Factors favor the appearance of a complicated form: immunosuppression, chronic respiratory disease, tracheal collapse, bronchitis, ciliary dyskinesia, intercurrent infection. Clinical signs. TBI is a syndrome, which can cause moderate to very severe clinical signs. Simple form: the clinical signs are a dry and strong cough. We speak of TBI dry, quintuous or even paroxysmal, due to inflammation of the vocal cords, and of laryngitis. The tone of the voice is particular. It sounds like a goose cry. Coughing may be productive, and expectoration efforts are likely to be confused by owners with vomiting efforts. We rarely see nasal or ocular discharge. There are usually no other abnormalities on clinical examination. This form progresses towards healing in a few days or weeks. Complicated form can follow a simple form or occur directly. We then observe a deterioration in general condition, depression, anorexia, hypothermia, dyspnea, purulent mucus discharge possible. On pulmonary auscultation, the sounds are increased. Prevention. Vaccination. TBI is a syndrome in which several infectious agents are involved. Therefore, and because of the short duration of immunity to a mucosal infection, it is impossible to predict the duration of protection of vaccines against the syndrome. Effectiveness of vaccines. It has been shown that the level of serum antibodies directed against Bordetella bronchoseptica during parenteral vaccination is higher than the level during intranasal vaccination. However, this rate does not predict protection against infection. Virulent tests show that puppies vaccinated intranasally, live-attenuated agents, and parenterally, inactivated agents, are better protected than puppies who received only one of the two products. Immunization against vaccinable agents at least prevents the development of severe pneumonia, which can be fatal. Vaccines available. Parenteral, subcutaneous route, the following vaccines are available. Living attenuated, CDV and CADV-A serotype 2, which are included in the protocol. Of essential vaccines, core vaccines. Live attenuated, PIV5 and inactivated Bordetella bronchoseptica are available. For these last two vaccines, it is difficult to establish a duration of immunity. There have been problems with vaccines based on Bordetella bronchoseptica. There was a large difference between vaccine strains and strains circulating in the field. Thus, vaccinated animals could contract the disease. Since then, the laboratories have renewed the vaccine bacterians regularly to adapt them to the situation on the ground. Intranasal vaccine: we have bacterians, live attenuated, of Bordetella bronchoseptica and live attenuated viruses of PIV5 mainly, but sometimes also of CADV-A serotype 2. For parenteral vaccination, you can start from 6 to 8 weeks of age. A second dose should be administered 2 to 4 weeks later. The duration of protection is close to 1 year. Intranasal vaccination, live attenuated viruses and bacteria, makes it possible to induce local immunity while reducing local and systemic reactions due to parenteral vaccines. This type of vaccine is used to strengthen immunity before a foreseeable risk situation, entry into a kennel for the holidays. The vaccine can be administered at the time of the risk situation if it is not foreseeable. Puppies can be vaccinated intranasally from 3 to 4 weeks of age, as there is no interference with AUN locally. The establishment of immunity is rapid, but it lasts a short time, between 3 and 12 months. Vaccination against TBI is recommended when one has an increased risk of respiratory infection. For dogs that have never been vaccinated, we recommend 10 to 14 days before the risk situation, exposure, kennel, hospitalization. -2 parenteral injections. or 1 intranasal administration. Boosters must be given every year if the animal does not present any particular risk, or every 6 months for animals at risk, high density of animals, or dogs with risk factors such as tracheal collapse. Sanitary and hygienic measures. In order to prevent the occurrence of TBI in environments where several dogs live together, newly introduced animals or those that have participated in competitions or stayed in kennels must be isolated for 2 weeks. It is absolutely necessary to avoid overcrowding and apply the standards of temperature, 21 to 25 degrees Celsius, humidity, 50 to 65% hygrometry, and ventilation, 10 to 15 liters/h. Cleaning and disinfection of premises and bowls using usual disinfectants or hot water vapor must be strict. Parvovirus infection (CPV) is a contagious viral enteritis, common in dogs. It is one of the most common infectious diseases in dogs throughout the world. Young animals, puppies between 6 weeks and 6 months, less than 1 year old, are more likely to develop severe disease, but unvaccinated or poorly vaccinated adult dogs are also at risk. Thanks to vaccination, the incidence of the disease has greatly reduced, but epidemics continue to occur. The prevalence of CPV in puppies and adult dogs presented to veterinary clinics for acute gastroenteritis is 28% in Spain, 54% in Italy, 62% in France, 71% in Germany, 88% in the United Kingdom and 40% in Belgium. It is recognized as being the main, deadly pathogen in young dogs less than 1 year old. Etiology. The infectious agent responsible for parvovirosis is canine parvovirus type 2, CPV2. Classically named, canine parvovirus. It was reclassified as a variant of the feline panleukopenia virus, FPV, in the official nomenclature of the International Committee on Taxonomy of Virus, 2012. It belongs to the genus Parvovirus, of the Parvoviridae family. It is a single-stranded, non-enveloped DNA virus, Decaro and Bunavaglia. The target of CPV2 is dividing cells, in whose nucleus it divides. These dividing cells are crypt enterocytes, lymphoid cells, hematopoietic stem cells of the bone marrow and the fetus, puppy cardiomyocytes and kitten Purkinje cells. It is the release of the virions, which leads to the lysis of the host cell. Etiology. Physiochemical characteristics. Canine parvovirus is very resistant in the external environment. Survive up to 1 year, in the external environment, at room temperature. On inert materials, floor, shoe soles, bowls. Resists many hygienic and aggressive treatments, detergents, solvents, 60 minutes at 60 degrees Celsius. Persists at a pH below 3, so it can survive in the stomach, before reaching these target cells, in the intestine. Destroyed by ultraviolet, bleach, formalin, glutaraldehyde, very effective, but toxic, for animals, and by washing for 1 minute at 100 degrees Celsius. Historical. CPV2 was discovered in the 1970s. It appears to derive from FPV or a related virus. It only infects dogs and is responsible for outbreaks of fatal hemorrhagic gastroenteritis and myocarditis in kennels worldwide. Viral circulation and vaccination have made it possible to develop immunity in the dog population, which has significantly reduced mortality. On the other hand, the selection pressure carried out by host immunity has surely contributed to the progressive emergence of antigenic variants of CPV2. In the 1970s, the CPV2A appeared. It is capable of infecting dogs and cats. CPV2B was discovered in 1985. In 2000, we saw the appearance of a new variant in Italy, CPV2C. It comes from a variation of the new CPV2B. This mutation modifies its antigenic power. In 10 years, it has spread all over the planet. The European strains are very similar to each other. The American strains are close to the European strains. Strains from other continents are dispersed among the CPV2A and 2B branches of their countries and are therefore more distant from other CPV2C. Receptivity. CPV affects domestic and wild canids, such as red foxes and grey wolves, as well as felids such as domestic cats. Evidence of natural infections has also been found in mustelids, badgers, martins and otters, and vivarids. It has also been detected in bears in Italy. Experimental infections have been carried out in domestic ferrets, minks, and cats. The host spectrum is different for the variants of parvovirus. Indeed, CPV2 only infects dogs, while CPV2A, B, and C infect dogs and cats. In China, a study found a new variant of CPV2A in giant pandas causing vomiting, diarrhea, and mortality. This study demonstrates that the virus adapts to new host species, which now include endangered wild species. Pathogenicity of strains. Variants of canine parvovirus do not seem to have the same pathogenicity. Indeed, CPV2 is less pathogenic than CPV2A and B. On the other hand, we cannot say which variant is the most virulent because this has not been proven in vitro or in vivo. It appears that the variants have a similar pathogenicity, which depends mainly on field conditions, such as the animal's age, immune status, and stress factors. Distribution of CPV variants worldwide. According to the following table, we note that CPV2B and C are the most present. Transmission. There can be direct transmission, via the fecal-oral route, or indirectly via the coat, objects, cages. The virus can survive in the environment for several months. Vertical transmission has not been described. The virulent materials come from infected dogs and cats, clinically or not, which excrete the virus in the feces and their coat, via licking. The urine and saliva of animals showing clinical signs are also infectious. Pathogenesis. CPV preferentially infects its target cells, dividing cells, intestinal crypts, and lymphoid organs. However, the virus can affect all tissues, even the brain. After entering the body via the oronasal route, the virus replicates in the GALT, lymphoid tissue associated with the intestines, and disseminates into the crypt epithelium of the small intestine, resulting in diarrhea. The weakening of the mucosa allows translocation of bacteria into the blood and leads to sepsis. Infection of leukocytes is the cause of lymphopenia. In puppies 2 to 3 weeks old, CPV can replicate in heart cells and cause fatal myocarditis. This form is observed less and less because puppies are protected by MAB. It can be observed in dogs that have not taken colostrum at all. Population at risk. All canines are naturally sensitive to CPV2. Dogs, cats, and wild felines are sensitive to CPV2A and 2B. Only cats and dogs are sensitive to CPV2C. Most affected dogs are between 6 weeks and 6 months old. As the virus is very resistant, in the environment, there is no need for direct contact to become infected. A puppy living alone can be contaminated by its owners, who bring the virus home via inert objects, such as shoes. Favoring factors. Certain factors promote, trigger, the disease. Casaliu, 2009. Age. The younger the puppy, the more severe the disease. At the time of weaning, a new digestive flora is established, which increases the mitotic index of the cells. However, the target cells of CPV2 are those in division. Weaning is therefore a very risky period for puppies. Immune status, which depends on the quality and quantity of maternal colostrum ingested. The presence of concomitant diseases. Breed. Crossbred animals seem less affected. Dobermans, Rottweilers, American Staffordshire Terriers and German Shepherds seem more sensitive, although we cannot explain why. Sex. Uncastrated males would be more sensitive. Clinical. The virus infects cells of gastrointestinal tract, thymus, lymph nodes, and spinal cord, causing malabsorption, increased intestinal permeability, and leukopenia. The severity of clinical signs depends on the viral strain, age, and immune status of the host, in particular, colostral intake in puppies and the quality and quantity of maternal antibodies, stress factors, withdrawal, overpopulation, and the presence of opportunistic infections. Parvovirus is characterized by high morbidity, 100%, and significant mortality of up to 91%. The rate ranges from 10 to 91%. Clinical infections are also common. According to Casallu, 2009, we can distinguish two presentations of parvovirus. Enteric form mainly affects puppies between 2 and 6 months. It manifests itself by the following signs: lethargy, prostration, anorexia, hypothermia, then vomiting, dehydration, weight loss, abdominal pain. In the next 24 hours, the diarrhea becomes hemorrhagic, foul-smelling, black. Marked leukopenia is observed. The severity of the attack depends on the ALM titer at the time of infection. Mortality can be up to 70% in puppies, but it is less than 1% in adults. Cardiac form is quite rare, it mainly concerns puppies under 6 months old. We then observe dyspnea, complaints, prostration, heart murmur and congestive heart failure. Clinical diagnosis. A. Prevalent age. CPV2 readily infects young puppies aged 6 weeks to 6 months. B. Suspicious signs: sudden acute vomiting, diarrhea, bloody diarrhea, apparent stench, low body weight. C. Cardiac-emograph, CKG, examination. CKG can detect abnormal wave pattern if sick dogs have myocardial damage or chronic myocarditis due to CPV2 infection. A. Hematological methods. CPV2 commonly causes canine leukopenia. White blood cells, WBC, would decrease to 500-200 WBC per microliter, an even lower amount in severe cases. For enteritis symptoms, lymphopenia would be a more important diagnostic indicator than leukopenia. If the white blood cell count recovers, it indicates that the infected dog has moved beyond the crisis stage and has gradually recovered. In addition, hematocrit, PCV, is a variant of the state of dehydration or intestinal hemorrhage. Bloody diarrhea would likely induce mild dehydration and cause elevated CPV. While gastrointestinal bleeding can decrease the degree of PCV, especially after fluid infusion. B. Biochemical test. Biochemical tests usually show several conditions such as electrolyte imbalance, hypokalemia, pre-renal azoturia, increased bilirubin, elevated serum CRP, elevated serum TNF, low serum cholesterol, and low serum albumin. C. Endocrine analysis. CPV2 infection would result in low serum thyroxine and high serum cortisol. D. Virus identification. It is the most specific diagnostic method for detecting CPV2, which includes electron microscopy, hemagglutination, HA, test, CPV2 isolation, ELISA, PCR and real-time PCR, viral test 3 to 12 days shortly after CPV2 infection. D.1. Electron microscopy. CPV2 could be easily detected by negative staining and use of electron microscopy during the acute phase. EM could also be used to identify CPV or FPV. D.2. Immunochromatography test, TIC. The commercially available IC test is a simple and rapid tool for clinical examination, which detects the 3 variants of CPV2, CPV2A, 2B and 2C. D.3. Hemagglutination assay, HA. The HA is a simple and rapid test to detect the agglutination effect of CPV2 with dog red blood cells at 4 degrees Celsius. The heart titer is generally located between 128 and 10240 R. The heart test generally shows a nonspecific result when the heart titer is less than 33 R. D.4. Isolation of CPV2 virus. The CPV virus can be isolated and grown in cell culture in MDCK, made in Derby canine kidney, or CRFK, Crandall feline kidney, from cases of CPV-induced myocarditis and enteritis. A canine cell line, A72, derived from a canine SC tumor is particularly useful for CPV isolation and CPV growth. However, low sensitivity, need for trained cell culture personnel, long incubation period, 5 to 10 days, are listed as disadvantages of the virus isolation method. D.5. ELISA. The ELISA test is rapid, inexpensive and easy to perform, based on antigen-antibody reactions. Recently, it reported that monoclonal antibodies could sensitively bind to 1.5 nanograms of CPV antigen by ELISA test. In addition, the double sandwich ELISA test is even more rapid, sensitive and suitable than the traditional ELISA test. This test has become a routine diagnostic method for CPV in dogs worldwide for antibodies and antigen. D.6. Polymerase chain reaction, PCR. Polymerase chain reaction, PCR, technique is a rapid, sensitive and accurate diagnostic tool, which has been used to detect viral infection. PCR can even identify less virus DNA than other tools. Specifically designed primers could recognize different types of CPV, CPV2, CPV2A, CPV2B and CPV2C. Prevention. With live attenuated virus vaccines containing CPV2 or CPV2B. They are very effective, they often protect against infection and disease, and are very safe to use, rare post-vaccination reactions. Only Canigen Puppy 2B, Virbac, contains Type 2B, IRCP, 2013. Vaccination is done subcutaneously. Opinions differ regarding the protection of vaccines based on CPV2. Some authors suggest that this vaccine protects against all variants. Others believe that vaccine-induced immunity is effective against homologous strains, but much less so against variants, thus allowing infection by a virulent strain and even death in properly vaccinated dogs. We have no evidence of the absence of cross-protection between CPV and the new variants. Thus, the primary cause of the widespread circulation of the virus despite vaccination would be either the interference of ALM in young vaccinated puppies, or a poor functioning of the immune system of old dogs. The vaccination currently used is as follows. Primary vaccination. Puppy less than 3 months old. First injection, between the 7th and 8th week of age. Second injection, 3 to 5 weeks later, not before the 12th week of age. Puppy over 3 months, 1 single injection. Prevention. The Duromon, Zoetis, and Primodog, Merial, vaccines have a starting age for primary vaccination at 6 weeks. The Nobivac Puppy, MSD, vaccine offers a first injection, from 6 weeks of age, then normal protocol. 3 injections in total for the primary vaccination. Revaccination, annual and before any entry into a risky environment. Kennel, gathering some vaccines have a higher booster interval by demonstrating the duration with virulent tests. Indeed, for Nobivac, MSD, and Duromon, Zoetis, after a first booster at 1 year, we can be satisfied with revaccinate the animal every 3 years. The Eurocan P vaccine, Merial, recommends, after a first booster at 1 year, boosters every 2 years. As parvovirus is a disease that is still present in farms, they have proposed adapting this protocol to the immune status of the farm. First of all, to be able to say that a vaccination protocol is effective, we rely on the absence of clinical parvovirus prevention. Free breeding of parvoviruses. It is interesting to carry out 3 administrations as a primary vaccination. The first at 6 weeks, with a surtitrated monovalent vaccine, the second at 8 weeks, with a multivalent vaccine. Then we repeat the injection around 3 months. Contaminated breeding, we vaccinate the puppies every 7 to 10 days, starting 7 days. Before the critical period, in practice, we take the age of the puppies previously affected. Thus, a puppy can be vaccinated from the age of 3 weeks if necessary. Other vaccine valences must be avoided, so as not to distract the immune system, as long as the puppy lives in a contaminated environment. The first injection of multivalent vaccine will be given around 9 to 10 weeks of age, the second around 12 to 13 weeks. This protocol is quite difficult to have breeders accept, who do not want to sell puppies not vaccinated against other infectious diseases. Regarding the duration of protection of the live attenuated virus vaccine based on CPV2, it appears to be several years. The minimum duration of immunity, DOI, varies depending on whether it is based on serology or response to a virulent challenge. Prevention. With the live attenuated vaccines, offer protection against the clinical signs, mortality and viral shedding of canine parvovirus. Hygienic measures to combat CPV2 infections and its variants are the same as for other pathogens. On the other hand, we can consider disinfection with disinfectants having strong virucidal power, effective on naked viruses, such as diluted sodium hypochlorite, or Virkon, potassium monopersulfate. Several coronaviruses, CoV, are responsible for coronaviruses in dogs. They belong to the family Coronaviridae, to the genus Alpha Coronavirus, and to the species Alpha Coronavirus 1. These are enveloped RNA viruses, associated with enteric or respiratory diseases. The phylogenetic tree distinguishes between genera of coronavirus: Alpha Coronavirus, human CoV 229E, canine CoV, feline CoV, certain animal CoVs bat, Alpha Coronavirus type 1, a variant of which is CoV. Beta Coronavirus, human CoV HKU1, SARS virus, severe acute respiratory syndrome, bat CoVs. Delta Coronavirus, CoV of birds. Gamma Coronavirus, avian CoV, beluga whale CoV. Coronaviruses are fragile in the external environment. Cough can be inactivated by most disinfectants and detergents. Canine enteric coronavirus, COV, is divided into 2 genotypes, type I and type II. The virus normally replicates in the intestine, but it is capable of replication in the lungs, liver, spleen, and brain, causing death in some dogs. There is a large difference in virulence between strains. Normally, cough infections are mild, fever, depression, anorexia, diarrhea, or even asymptomatic. However, there are more virulent strains. A hypervirulent variant of cough type 2 was the cause of an outbreak of severe gastroenteritis in a group of beagles in the United Kingdom. Likewise in Sweden, during an episode of fatal canine gastroenteritis, a possible recombination between 2 cough genotypes was mentioned. A highly pathogenic pantropic variant of cough type 2, strain CB/05, was identified in a dog breeder in Italy. Epidemiology: cough is present worldwide with a significant prevalence in kennels and dog shelters. Population at risk: animals of all ages are susceptible, but newborns are especially so. Morbidity is high and mortality is low. Mode of transmission: the virus is very heavily excreted in the feces for 6 to 9 days. This period may be longer in some animals. Transmission occurs via the fecal-oral route, Tennant et al., 1991. Incubation period: the incubation period is short, between 1 and 4 days. Pathogenesis: the infected animal excretes the virus 3 to 14 days after its infection, and this for a period of 6 to 9 days. The virus infects the epithelium of the villi of the small intestine, where it multiplies rapidly. Infected cells are changed and there is a loss of microvilli, leading to digestive signs. It is an enteropathogenic virus. Clinical signs: the classic cough infection is restricted to the digestive tract. We therefore have signs of gastroenteritis, anorexia, vomiting, very liquid orange and smelly diarrhea, dehydration. Animals rarely die from coronavirus disease. If so, there is often concomitant infection with CADV-A serotype 1, CPV or CDV, Tennant et al., 1991. Most animals recover spontaneously within 8 to 10 days, Green, 2006c. The animals exhibited clinical signs, fever, lethargy, anorexia, vomiting, hemorrhagic diarrhea, nervous signs, ataxia, convulsions, leukopenia and died within 2 days. Anatomopathological are described hemorrhagic enteritis, abundant serohemorrhagic fluid in the abdominal cavity and severe lesions on the parenchymal organs, hemorrhages on the lungs, kidneys and liver. Prevention. Live attenuated and inactivated vaccines are available in the United States. However, like coronaviruses in dogs, they are often benign conditions that occur resolve alone. The use of this vaccine is useless, even in breeding. Vaccination is even not recommended, even when infection is confirmed in livestock. Canine respiratory coronavirus, cough, is very contagious. A variant of cough, it is distinct on genetic and antigenic levels, it therefore requires specific tests for diagnosis. Infection with cough alone would only cause mild to clinical respiratory symptoms. However, virus replication could cause damage to the pulmonary epithelium and the ciliary escalator. This would allow secondary bacterial infections, and we could see a TBI appear, with marked respiratory signs. In dogs, Rotavirus enteritis is caused by the canine rotavirus, CRV, part of the Rotavirus species. It belongs to the Reaviridae family and the Rotavirus genus. It is a non-enveloped RNA virus, looks like a wheel, rota. The virus is rather resistant in the environment. Rotaviruses are potentially zoonotic. Mode of transmission is by the fecal-oral route. Pathogenesis. Rotavirus infects the epithelial cells of the intestine. Then it spreads by destruction of infected cells. They degenerate and slough off in the intestinal lumen, where they relegate a large number of virions. This therefore constitutes a source of contamination for the following intestinal segments, and for other animals. Within 18 to 48 hours following infection, the cells necrotize and are rapidly replaced by immature crypt epithelial cells. Dogs experimentally infected with rotavirus do not exhibit diarrhea, but they excrete the virus in the feces. It has been shown that dogs can be infected with rotaviruses of different species through direct contact. Dogs could therefore play a role in the transmission and dissemination of rotavirus between humans and other animals. Environmental contamination by dogs represents a real health problem. Clinical signs. Rotavirus infections are very common among young people, men and animals. The infection may be associated with enteritis and mucoid to watery diarrhea, more often on puppies less than 12 weeks old. It can be asymptomatic in adults and animals that have received their colostrum correctly. Prevention. There is no vaccine against CRV. However, hygiene measures and correct colostrum intake can prevent infection. West Nile virus, WNV, is an enveloped RNA virus of the genus Flavivirus, of the Flaviviridae family. This virus is unstable in the environment, and is quickly inactivated by common disinfectants. It infects birds and many mammals, horses, sheep, alpacas, squirrels, rodents, bats, wolves, cats, raccoons, skunks, rabbits, including humans. Clinical. Illness in dogs is rare, although the virus circulates within the dog population. Experimental infection of dogs by mosquitoes led to clinical infections, or to mild, transient pyrexia in one individual. Several clinical cases, following natural infections, are described in the literature, and come from Africa and the United States. Dogs that have developed an illness have neurological clinical signs, generalized tremor, ataxia, head tilt, blindness, rocking movements, neck pain, lack of proprioception, tetraparesis and systemic, diarrhea, abdominal pain, serous oculonasal discharge, conjunctivitis, cardiac arrhythmia, myocarditis, tachypnea, tachycardia, and stiff gait, due to mild neutrophilic polyarthritis. The diagnosis of the disease is made post-mortem. Lesions of encephalitis, myelitis, and myocarditis are evident. Prevalence. The seroprevalence of WNV in dogs in Europe ranges from 1.3% to 1.6% in Spain, up to 56% in Italy. In France, seroprevalence ranges from 6.7% to 8%. The areas where the virus is endemic among wildlife are located on the Mediterranean coast, particularly in the Camargue, a humid area conducive to the development of insects carrying the disease. Contamination way. Dogs become infected following the bite of an arthropod, a vector of the virus, mosquitoes such as Aedes albopictus. Transmission via these biting insects increases during the summer, peaking from July to October. Dogs are an epidemiological dead end. In fact, they do not produce sufficient viremia to infect new mosquitoes. Other modes of contamination are possible: ingestion by predation of infected birds or rodents, blood transfusions, following an injury from a contaminated needle, or even transplacental route. Viral MINK enteritis is a highly contagious disease caused by infection with MINK enteritis virus, a protoparvovirus related to that which causes feline panleukopenia. MINK of all ages are susceptible and morbidity is variable, with up to 10% mortality of affected animals, mainly kittens. Transmission is by the fecal-oral route and the incubation period is approximately 4 to 10 days. Clinical signs may include weight loss, poor coat, anorexia, depression, watery to hemorrhagic diarrhea, dehydration, and death. Affected animals may die from secondary bacterial enteritis. Gross lesions include flaccid, dilated loops of the small intestine with watery, sometimes hemorrhagic, contents. Some mink may die suddenly without significant damage. Microscopically, intestinal lesions are characterized by erosion or ulceration of the mucosa, with blunting and attenuation of the villi and dilation of the crypts. The epithelial cells of the ballooned crypts may contain basophilic intranuclear inclusion bodies. Confirmation diagnostics, by ELISA, or fluorescent antibody, are used. Splenic and lymph node lesions include lymphoid depletion and necrosis. At the start of an outbreak, all minks showing clinical signs should be culled or isolated, and all clinically normal mink should be vaccinated immediately. Affected mink can be treated with a mixture of kaolin, pectin, and neomycin, administered orally. Mink viral enteritis can be prevented by vaccination. All mink should be vaccinated when they reach at least 6 to 8 weeks of age, with a multivalent vaccine containing mink enteritis virus, Clostridium botulinum toxoid and Pseudomonas bacterium. Annual vaccination is recommended. The virus is very resistant in the environment, is inactivated at high pH. Differential diagnoses include other viral and bacterial causes of enteritis. AlEOUTIan disease, or ADVERB, is caused by a parvovirus that affects mink, ferrets, skunks, raccoons and probably other mustelids. It is a very resistant virus in the external environment, and it is necessary to use virucidal disinfectants or bleach diluted to 10% to eliminate it. It exists in several forms because it has the ability to mutate easily like the flu virus. The different variations are more or less contagious and more or less fatal. Historically, the virus was first observed in mink in the 1940s, in which it is very virulent and quickly fatal, whereas it appears chronically and more or less latently in ferrets. The virus does not act directly on the organs, but it causes an autoimmune reaction. Indeed, the presence of the virus induces the production of a large quantity of antibodies, especially gamma globulins. These combine with antigens, viruses, to form antibody/antigen complexes which are deposited in the tissues of multiple organs, such as the kidneys, liver, bile ducts, spinal cord, digestive tract, walls of blood vessels and the bladder. The presence of these complexes leads to an inflammatory reaction, with accumulation of white blood cells, mainly plasmacytes and lymphocytes. If the inflammation is moderate, the ferret appears clinically normal, no symptoms. If the inflammation is strong, the ferret shows signs of the disease depending on the organ or organs affected. This damage to the immune system promotes other infections, such as intestinal viruses, distemper, and other diseases. The exact mechanism by which the virus affects the immune system is not known, but the resulting inflammatory reaction can be observed under a microscope. The incubation period are unknown. Symptoms appear 1 to 2 years after contamination. Most of the time the animal remains healthy. The period of viral shedding are unknown. The virus is present in saliva, urine, stools and passes through the placenta. It also persists on contaminated items, such as the cage, linens, gloves, clothing, hands. Some EU studies have shown that the virus can be transmitted by air, however this is not verified in practice. Obviously, close and prolonged contact with an affected animal or contaminated items is required. An affected ferret will not inevitably manifest the disease. Less are known about how the virus is transported, how long the infection lasts, or how much time are eliminated the viruses. On the other hand, we must admit that an animal testing positive is likely to excrete the virus at any time without symptoms. Symptoms at the start of the disease are extremely variable. There is no way of knowing whether or not the ferret will express the illness, nor when, nor how, nor with what intensity. It is important to note that the majority of ferrets that have been exposed to the virus will never develop the disease. Some ferrets are healthy carriers for several years before expressing the disease, others will never develop it, and finally some will become negative. It is a chronic wasting condition, causing significant wasting. The most common manifestation is ascending paralysis, that is to say which starts at the rear, and gradually rises towards the upper body. It is accompanied by muscle wasting. We also observe tremors, lethargy, pallor linked to anemia, dark stools, presence of digested blood, enlargement of the liver and spleen. Damage to blood cells, red blood cells, platelets, white blood cells, promotes the formation of hemorrhages and secondary infections at the end of the course. Many affected ferrets die of liver or kidney failure. However, all of these symptoms are present in other conditions, such as the presence of a foreign body in the stomach, eosinophilic gastroenteritis, distemper, liver or kidney failure, and lymphocytoma. Hypergammaglobulinemia is present at the end of the course. Diagnosis. We can carry out a protein electrophoresis test. We then see an increase in gamma globulins, these then representing more than 20% of total proteins. The total protein level is then 7.5 and the albumin level is slightly reduced. The macroscopic lesions, visible to the naked eye, are enlargement of the spleen and liver, as well as lymph nodes. We also see that the kidneys are stained. In the final phase, there is hemorrhage on the organs and blood in the urine. However, none of these lesions is specific to adverb. Microscopic lesions show tissue infiltration, with clusters of lymphocytes and plasma cells, in numerous organs such as the liver, bile ducts, kidneys, central nervous system, brain and spinal cord, blood vessels, the gastrointestinal tract, the digestive tract, and the bladder. These cell infiltrates in multiple organs are characteristic pathological signs of adverb, especially when there is also glomerulonephritis, a type of inflammation of the kidneys. The definitive diagnosis of adverb can therefore be made through microscopic examination of tissues from several organs, the kidneys, liver, bile ducts, intestine, spinal cord and bladder. Diagnostic confirmation. The CEP or counter-immunology electrophoresis test. This test looks for the presence of several proteins in the blood. It is positive if only one of them is detected, whether the virus is active or not. It is inexpensive and easy to make. It is the most used in the USA. However, it is not 100% reliable and can give false positive or false negative results. No studies have proven its effectiveness. The ELISA test identifies the presence of a protein, which is produced only when the virus is active and multiplies. The EFA, or immunofluorescence antibody test. This test is more efficient than the CEP, but it is more difficult to implement and more expensive. Its effectiveness is not proven. The PCR test makes it possible to search for the presence of a DNA sequence of the virus, but the antigenic diversity of the virus makes this test ineffective. Treatment. There is no specific treatment for this disease. Palliative care consists of syringe feeding if necessary, rehydration, administration of anti-inflammatories and other medications according to the symptoms expressed. This prolongs the life of the animal but does not cure it. There is no vaccine. It is even contraindicated to vaccinate because of the present immune disorders. Prevention. Disinfect. Good hygiene is essential because the virus is resistant in the external environment. It is necessary to disinfect with products. Virucides such as formaldehydes, sodium hydroxide, phenol compounds or bleach. Avoid contact. Contact with untested animals should be avoided. Do not let another person handle your ferret if they have not disinfected their hands. Don't let your ferret on the loose in your veterinarian's waiting room, for example. Respect quarantines. Isolate a new ferret until it is tested. For ferrets, it takes several months before the antibodies are present in the blood. Test the parents. The tests. There is no need to systematically test healthy ferrets. If a clinically normal ferret tests positive, there is no point in isolating it from its group because at the time of this discovery it is very likely that all have already been exposed to the virus. In breeding farms, a 1-month quarantine is necessary before introducing a new animal, and it is preferable to retest before integrating the animal. New to the group. Due to the unreliability of testing, all animals must be tested annually before the breeding season. In boarding houses and shelters, tests should be required no more than 4 to 6 weeks old. In addition, due to the unreliability of the tests, 2 negative tests should be required 1 month apart. It is therefore preferable and more effective to apply strict hygiene measures, disinfecting the environment, keeping ferrets in their own cage and avoiding contact with other ferrets. During exhibitions, the same problem of unreliability of tests arises. False negatives can enter the exhibit and a negative ferret may have come into contact with the virus just before exposure. The best means of prevention remains the application of good health measures. Surfaces and hands must be disinfected between each ferret. Do not put ferrets in contact, do not touch other people's ferrets or, if this is the case, disinfect your hands afterwards. Do not hold ferrets against your clothes. Fox encephalitis, a systemic disease caused by canine adenovirus 1, is also an important pathogen of foxes, dogs, wolves, coyotes, skunks, and bears. In fact, the virus was first recognized as the cause of fox encephalitis. In dogs, in addition to causing acute hepatitis, the virus can cause respiratory or eye disease. In contrast, canine adenovirus 2 infection is localized in the respiratory tract. Fox encephalitis, infectious hepatitis, is found wherever foxes are kept and remains a disease problem for long periods on large fox farms. The mortality rate is 2 to 40% of foxes on a farm. About 6 days after infection, the illness begins with a violent convulsion. The animal then seems to walk as if it were sleeping. A period of apparent normality follows, but convulsions recur, followed by a state of drowsiness. Flaccid paralysis is another common sign. Recovered foxes are immune for life. For prevention, the vaccine used to immunize dogs against infectious hepatitis should be administered shortly after weaning. Since the resulting immunity is not permanent, revaccination at annual intervals is recommended. Epidemiology and clinical signs. Adenovirus 1-induced disease is well controlled by vaccination in many countries and, therefore, most infections are subclinical, or manifest as undifferentiated respiratory disease. In some cases, particularly in the immunologically naive host, infection originates from the initial respiratory site to cause systemic disease. Systemic disease can be divided into 3 overlapping syndromes, which are usually seen in younger animals. 1. Per-acute illness, in which the puppy is found dead either without apparent prior illness or after an illness that lasted only 3 or 4 hours. 2. Acute illness, which can be fatal, marked by fever, depression, loss of appetite, vomiting, bloody diarrhea, petechial hemorrhages of the gums, pale mucous membranes and jaundice.
3. A mild disease, which may actually be a vaccine-modified disease, i.e., the result of partial immunity.
Incubation of acute disease is 4 to 9 days. Clinical signs include fever, listlessness, anorexia, thirst, conjunctivitis, serous discharge from the eyes and nose, and sometimes abdominal pain and petechiae of the oral mucosa. There may be tachycardia, leukopenia, prolonged clotting time, and disseminated intravascular coagulation. In some cases, there may be hemorrhage, e.g., bleeding around baby teeth and spontaneous hematomas. Although central nervous system involvement is not common, severely affected dogs may have seizures. 7 to 10 days after the disappearance of acute signs, approximately 25% of affected dogs develop a characteristic and diagnostically useful bilateral corneal opacity, which generally disappears spontaneously. In foxes, canine adenovirus 1 causes primarily a disease of the central nervous system. Infected animals may exhibit intermittent convulsions during their illness and, in the terminal phase, may suffer from paralysis of one or more limbs. Kidney infection is associated with voruria, which is a major mode of transmission, with stool and saliva. Recovered dogs can shed the virus in their urine for up to 6 months, are carriers. Pathogenesis. The virus enters through the nasopharyngeal, oral and conjunctival routes. The initial infection occurs in the tonsils and then spreads to regional lymph nodes and blood. Viremia results in dissemination in saliva, urine, stool, and infection of endothelial and parenchymal cells in many tissues, leading to necrosis, particularly in the liver, kidneys, spleen, and lungs. Canine adenovirus 1 is also one of several causes of acute respiratory illness, although it is probably less important than canine adenovirus 2. The syndrome that gives its name to the disease, infectious canine hepatitis, involves the massive destruction of hepatocytes, leading to per-acute death. Affected dogs. Invariably in such cases, histological examination reveals characteristic inclusion bodies in the hepatocytes. In the convalescent stages of natural infection as well as 8 to 12 days after vaccination with the attenuated adenovirus 1 vaccine, corneal edema, blue eye, may sometimes be observed. Although clinically dramatic and alarming, especially after vaccination, the edema generally disappears after a few days, without consequences. Edema is caused by the deposition of virus antibody complexes in the small blood vessels of the ciliary body, interfering with normal fluid exchange in the cornea. The lesions present in dogs with infectious canine hepatitis depend on the clinical course of the infection. A rapid clinical course results in edema and hemorrhage of superficial lymph nodes, with multifocal to diffuse petechial and ecchymotic hemorrhages on serosal surfaces. The liver and spleen are enlarged, with mottling of the splenic parenchyma and accumulation of fibrin on the serosal surfaces of the abdominal viscera. The gallbladder wall is typically thickened and edematous. Gross lesions in other organs may include cortical renal hemorrhages and multiple areas of pulmonary consolidation. Eye damage may include diffuse corneal edema and opacity. Liver histologic findings in severely infected puppies include multifocal hepatocellular necrosis and sometimes centrilobular hepatic necrosis due to disseminated intravascular coagulation (DIC). Intranuclear inclusions may be present in Kupffer cells and hepatocytes. These characteristic inclusions also occur in the kidney endothelial cells of affected dogs. There is usually widespread hemorrhage and necrosis associated with intravascular thrombosis in dogs that develop disseminated intravascular coagulation. In the convalescent stages of natural infection, as well as 8 to 12 days after vaccination with the attenuated adenovirus 1 vaccine, corneal edema, blue eye, may sometimes be observed. Although clinically dramatic and alarming, especially after vaccination, the edema generally disappears after a few days, without consequences. Edema is caused by the deposition of virus antibody complexes in the small blood vessels of the ciliary body, interfering with normal fluid exchange in the cornea. Sequential pathogenesis of CAV1 infection in the eye. A. During the period of viremia, CAV1 enters the eye via the uveal tract, localizing in the vascular endothelial cells of the choroid and causing mild uveitis. The virus also enters the aqueous humor and localizes to corneal endothelial cells. B. CAV1 specific antibody response increases in the blood and reaches the eye via the uveal tract and enters the aqueous humor in the presence of virus. C. The virus is free in aqueous and endothelial cells and the formation of a viral antibody complex and the intranuclear inclusion body. D. Complement fixation on free virus immune complexes and in endothelial cells to neutrophil chemotaxi. More severe uveitis and corneal endothelial injury occur. E. Close-up showing loss of endothelium and aqueous pump leading to influx of water into the cornea. F. Loss of corneal endothelial cells allows water to enter the cornea, causing corneal edema, blue eye. Once the mononuclear phagocytes have cleared the virus immune complexes and the inflammation has subsided, the corneal endothelium regenerates. G. Inflammation of the uvea can lead to filtration angle blockage and subsequent glaucoma. Illustration by Brad Gilliland, copyright 2010 University of Georgia Research Foundation. Confirmatory diagnosis of canine adenovirus infections is performed either by virus isolation, polymerase chain reaction, PCR, testing, or serology using an enzyme immune test, hemagglutination inhibition, or a neutralization.
Virus isolation is performed in one of several cell lines of canine origin, e.g., mid and Derby canine kidney cells.
Cytopathology occurs in most cases within 24 to 48 hours and, in addition to characteristic intranuclear inclusions, canine adenovirus 1 can be identified by immunohistochemistry and/or immunofluorescence staining. Prevention and control. Inactivated and live-attenuated canine adenovirus 1 vaccines have been widely used for many years. The antigenic relationship between canine adenoviruses 1 and 2 is close enough for the canine adenovirus 2 vaccine to have cross-protection. The vaccine against canine adenovirus 2 has the advantage of not causing corneal edema. Maternal antibodies interfere with active immunization until puppies are 9 to 12 weeks old. The development of neutralizing antibodies is directly correlated with immune protection, and dogs with high neutralization titers are protected against clinical disease. One of the most remarkable phenomena in veterinary practice has been the virtual disappearance of canine infectious hepatitis from regions where vaccination had been practiced for many years. This may in part be the result of shedding of vaccine virus by vaccinated dogs, thereby seeding the environment with attenuated vaccine virus, secondarily immunizing other dogs and creating a high level of collective immunity.